but I use it for every sedation. Anytime I get a chance to use end-tidal capnography, I will use it. It tells me a lot of things, not only from the kids' breathing, but also from their cardiac output standpoint. And that's why I like end-tidal capnography a lot.
Hi, everyone, and welcome to the PedScript podcast. My name is Zach Hodges, and I'm a current PICU fellow at UT Southwestern in Dallas.
And I'm Alice Shanklin. I'm a PICU fellow at Children's National in Washington, D.C.
Alice, will you remind our listeners what we do here at the PedScript podcast?
Absolutely. PedScript is a collaborative educational PICU podcast. We work with pediatric critical care educators around the world to create high-yield blog and podcast episodes on core PICU topics.
And listeners, if you're a pediatric critical care provider and would like to become involved in this project, be sure to reach out to us by email or on our website at pedscript.com. We're hoping to add to the online community of Peds ICU learners by collaborating with guest educators on their favorite critical care topics.
Yes, please reach out to us. We can't wait to hear from you. Zach, who are we talking with today?
We're excited to have Dr. Pradip Kamat with us once again today. This is the final part of a 3-episode series on pediatric procedural sedation. We discussed Dr. Kamat's clinical framework by walking through a few common scenarios. We also review rescue protocols for adverse events.
Yes, and in case you haven't met him before, Dr. Pradip Kamat is an Associate Professor of Pediatrics at Emory University School of Medicine and a practicing pediatric intensivist at Children's Healthcare of Atlanta. He is well known for his leadership in pediatric procedural sedation, and we are so excited to have him for this 3-part series.
Absolutely. Let's jump right into part 3 of our conversation. I want to get practical. So let's say you've decided a patient is appropriate for sedation. They're bringing them in. How do you prepare for this sedation? What do you need to make sure you have available?
That's another good question. You are never prepared enough. What I do is they tell me patient in room 1 is ready for the MRI. First of all, I look at the patient's chart. I'll make sure that, if there is any previous sedation or previous anesthesia encounter, I make sure the patient is easy to bag mask. I make sure the patient, whatever medications were given before, were well tolerated, because if the patient reacted to, for example, midazolam that was given for an IV placement in the past, I do not want to repeat the same mistake again. So I'll go through the electronic medical records again. I will sometimes even make a mental note of how much propofol the child needed for induction and how much propofol the child needed for maintenance, because I know it is going to be somewhere close this time around. Then what I do is I take a history. The nurses do a history, but I always like to go and take an history just to kind of familiarize myself with the child and the family. I'll ask about allergies, what medications they take, if there's any snoring when they sleep, or any other abnormal noise they make while breathing. I'll ask about their last meal, or how long they have been fasting, and any recent new illnesses, like a recent new upper respiratory tract infection. I'll ask all that information. And then I do a physical exam on the child, and more focused on airway. Does the kid have normal facies, a good submental distance? Can they open their mouth wide? I usually don't focus a lot on malam patti in very small kids, but I look at their tongue size. I make sure they don't have any other syndrome like midface hypoplasia, as Zach has already pointed out before. So, and then after that, I will explain what I'm doing to the family, how the procedure is going to be done from a sedation standpoint. Once I do that, I then ask for consent, tell them all the risks. Sometimes I even tell them your child may slow down their breathing, hold their breath, or even frankly stop breathing. And then I tell them what I have ready. And that comes to a lot of mnemonics different people use, like Mismade or Soap Me. And basically what it involves is having your airway equipment ready, including bag, mask, ventilation, suction, having all your medications ready, having what you call as a code sheet ready with all the basic medications that can really quickly be given to the child. We also use what is called as a sedation reversal kit. It has naloxone in it. It has flumazenil in it, and it also has succinylcholine as well as atropine. We call it a sedation reversal kit. I keep that ready for every child we sedate. I never rely on anybody else when they tell me I have your bag mask ready. I personally want to test it, make sure it's ready to go. And this is not because I don't trust people. This is just put another checklist on there to make sure that it's kind of ready to go.
Oh, absolutely. Always trust but verify.
Yeah.
So you've got your naloxone for opioids, flumazenil for benzos, and then you have atropine and succinylcholine. What specifically do you anticipate using succinylcholine for?
Yeah, succinylcholine is a muscle relaxant that is very short acting.
Mhm.
And historically, it's anesthesiologist's drug of choice for a laryngospasm that doesn't break. But what we have found out more recently is even if we have a true and true laryngospasm, really bagging the child and just deepening them with a lot of propofol
Mm.
opens the laryngospasm. And so it has been a long time since we have really used succinylcholine in outpatient sedation, at least at our center. But, there's always a possibility you may need it. That's why we have it. So what if the laryngospasm doesn't break with deepening with propofol? The next go-to drug will be succinylcholine. Succinylcholine, when given for laryngospasm, typically also produces bradycardia. That's why we have a little bit of atropine ready too. So we give both the drugs together so it counters the bradycardia that we get from succinylcholine.
Gotcha. On the topic of laryngospasm, rare, life-threatening, and the PICU Doc on Call podcast, I think you guys discussed that pretty extensively in one of your episodes. Highly recommend the listen.
Thank you.
Let's say you're about to start the sedation. Are there any particular special types of monitoring that you typically use?
Yes. First of all, direct observation whenever possible is one of the best things in sedation. So where for really very short procedures, you have to be there where you can directly observe your patient. We use monitoring of the heart rate, blood pressure. We use a pulse oximetry on the patient. And I highly, highly, highly recommend end-tidal capnography.
Mm-hmm.
The American Academy of Pediatrics has a paper on what's required for moderate sedation versus deep sedation. Every deep sedation requires end-tidal capnography for monitoring, whereas moderate sedation, it's a recommendation to use, but I use it for every sedation. Anytime I get a chance to use end-tidal capnography, I will use it. It tells me a lot of things, not only from the kids' breathing, but also from their cardiac output standpoint. And that's why I like end-tidal capnography a lot.
Oh, wow. Yeah, that's very interesting.
And thinking about the waveform capnography, you want to help review with us maybe some common abnormalities that you might detect and how you would go about fixing that?
Yeah. So when you use end-tidal, it provides you two things. It basically gives you a nice waveform, and it also gives you a number. I usually don't look at the number. I usually look at the waveform. There is a great website called capnography.com. Highly recommend everybody go to that website. Again, it is called capnography.com. It has even a lot of pediatric end-tidal information. So what I do is I tell all nurses the end-tidal waveform is the most important when a child is deeply sedated. And that is what they really need to watch for. Besides everything else they watch, like heart rate and blood pressure, they have to watch that end-tidal waveform. If that end-tidal waveform disappears, they have to assume the worst thing, which can be apnea, complete airway obstruction, such as laryngospasm. You get a good end-tidal waveform when you have good cardiac output. For any reason, the cardiac output is not there. For example, I'm just throwing this example, doesn't happen. If the patient has cardiac arrest, the end-tidal waveform will not be there till you start doing some sort of chest compressions. In fact, American Heart Association recommends the use of end-tidal capnography to see how good your chest compressions are. End-tidal waveform itself gives you so much information. Is the airway open? Is the airway obstructed? Is the child breathing or is the child apneic? A normal cardiac output. It gives you all this information. Therefore, I really, really want to use end-tidal for every sedation I do. The other thing that the end-tidal sedation does for me is kind of indirectly tells me about the depth of sedation. What it does is there are two types of hypoventilation scenarios you can get. You can get something called as bradypneic hypoventilation, where the patient maintains their tidal volume, but the rate of breathing is very slow. This is typically what a teenager will do when you deeply sedate them. They may be breathing, 10, 12 times a minute, but they're maintaining their tidal volume. So this is called as bradypneic hypoventilation. There's something else that you can get is called as hypopneic hypoventilation, which a smaller baby may do, where they maintain the rate, meaning they may be breathing 22 times a minute, but they are unable to kind of keep that tidal volume, and they may be breathing very shallowly for you. And so therefore it is called as hypopneic hypoventilation. Both are concerning. You need to make sure that the airway is okay, or you can lighten your sedation there. For your listeners, more important than that absolute end-tidal number is actually the waveform.
Wow. I love your distinction between bradypneic hypoventilation, slow breaths, normal tidal volume, and hypopneic hypoventilation, normal rate, low tidal volume. And I think it's so interesting and intuitive the way that younger kids will just be hypopneic and older kids will be bradypneic.
It also seems that you'll see abnormalities on your waveform capnography even before you would see a low oxygen saturation. Is that right?
Correct. And that's a fantastic point. I actually missed that. So what happens is it will take your pulse ox a good 2.5 minutes if a patient goes apneic to start dropping and getting your attention. But end tidal waveform, that change will be immediate. Therefore, nurses and others need to be really hyper vigilant about that end tidal waveform. Excellent point.
Well, Dr. Kamat, this has been an excellent conversation. So much good practical stuff that we can take to our sedation rotations or next time we're at the bedside taking care of a child, especially in an outpatient setting, providing procedural sedation. I thought we might finish off with some practical cases. I want to hear what you would think about these cases, which medication would you choose, and hear more about why you think that.
Absolutely.
So our first case, 3-year-old who needs a 45-minute long MRI. So how do you think about choosing an agent for that patient?
6 and above, you can bribe them and you can tell them, hey, go into the MRI. A 3-year-old is not going to do that. Okay, first of all, they're going to be angry and upset that we did not feed them for a long time. They're also going to get angry and upset because you need the IV either for contrast or for sedation itself. And given stranger anxiety, different place, the child is woken up early in the morning to come to sedation, the child is overall going to be very unhappy. So this is a child, just from the length of that procedure and to get a good study in one trip, you are best using propofol, provided there are no contraindications to propofol use, which are very few actually. And so I would place an IV in this child and I'm going to use propofol. Typically, we use somewhere between 2 to 3 milligrams per kilo for induction dose. And then once the child is asleep, then I would maintain the child anywhere between 5 to 6 milligram per kilo per hour of propofol. And then place the child in the MRI, do end tidal monitoring and all the other monitoring. Once the child finishes the MRI, I would stop the propofol. I typically tell parents, do not rub the kid, do not move the kid. Let the kid just sleep because the kid is probably going to sleep for another 15, 20 minutes once you stop the propofol. And then the child is going to spontaneously wake up. And once the child wakes up, you can give the child something to drink or eat.
So if I'm understanding correctly, propofol is right because it's a painless procedure. Do you want something that's quick on and quick off?
Correct.
And also propofol helps that child remain completely immobile.
That's correct.
Excellent. What about a 7-year-old that needs a bone marrow biopsy? This is pretty invasive and pretty painful.
When you say invasive and painful, so we'll definitely need a good analgesic agent, which could be ketamine or fentanyl. My go-to agent is fentanyl. These patients also need sedation in the sense they will also need immobility. And remember, you also need an agent that provides amnesia for that procedure because a lot of these hem-onc patients get these procedures very frequently. And what you don't want them to is remember that procedure and develop some sort of a post-traumatic stress from that procedure. So the way I would sedate this 7-year-old is we usually give about 1 microgram per kilo fentanyl, and we usually max it out at 50 micrograms, meaning if the child is 75 kilos, I wouldn't give 75 micrograms or 100 micrograms. We have seen that usually about 50 micrograms, slow push is more than enough. Once the fentanyl is given, I wait about 5 to 7 minutes, and then I start pushing propofol. Typically, 1.5 to 2 milligram per kilo is what's needed to induce the child. Because the bone marrow biopsy is a short procedure as compared to the first kid we discussed for the 45-minute MRI, here you do not need an infusion. You can just give small aliquots of propofol, give about 0.5 to 1 per kilo and just keep sedating the kid by giving them small aliquots of propofol as the procedure is being done. I also recommend that the hem-onc team uses a lot of local anesthetic prior to doing the bone marrow because all this combination of fentanyl, propofol, local anesthetic make the sedation experience for that patient a good one.
Oh, excellent. So you've got fentanyl for the pain and then propofol to assist with immobility, but also really so that this kid won't remember the procedure.
Correct.
Hey, a question about this case. So what would be the advantages or maybe disadvantages for using something like ketamine instead of propofol and fentanyl?
No, you can use ketamine. I mean, in fact, I will tell you a lot of institutions, especially outside the US, do not allow non-anesthesiologists to use propofol. And a lot of these procedures are done just by using ketamine with a little touch of midazolam or some other benzodiazepine. And it is perfectly okay to do that. We are a propofol center.
Mhm.
We use propofol. We like the real quick on and off effect of propofol. So we use propofol. The other disadvantage in kids who have cancer, they're usually on chemotherapy. They have a lot of emesis or are prone to have emesis. And one of the side effects of ketamine, especially after the procedure is done, is vomiting. So I usually stay away from ketamine in patients who have cancer and are receiving chemotherapy. Do not get me wrong. Ketamine is a perfectly fine analgesic agent to use in these kids. We just don't use it because we are more used to fentanyl and propofol.
Oh. Dr. Kamat, do you feel like, at least in the United States, ketamine is just maybe more of a culturally an emergency department drug?
Correct. That is absolutely correct. Some of my ER colleagues actually use ketamine even at our center when they do procedures because they're just more used to it and they're more familiar with it.
So finishing up with our last case, how about a 4-year-old who needs a urinary catheter placed for a VCUG?
These are the procedures just like IV placement or joint injection, which are not typically very painful, but they're very distressful for the patient, and you can consider them as partially invasive. A good agent for these patients, lately we are finding out, is actually nitrous oxide. And so we have a good portable nitrous machine that we use, and we typically give anywhere from 50% to 70% nitrous to these patients for about 2.5 minutes. And then nurse is going to place the catheter. She also uses a lot of local anesthetic gel with the catheter, so it's not painful for the patient. Nitrous provides good sedation. It provides some mild analgesia, and it is really good for that patient who's anxious about this procedure, which is not typically very painful. Mm-hmm. If you do not have access to nitrous, you are not wrong in using an agent like midazolam, which provides the anxiolysis that you need for this distressing procedure. We were using a lot of midazolam in the past, but lately we have been using nitrous, and the parents have been actually asking for nitrous because they feel like their child's experience with nitrous is much better than using midazolam.
That's great.
So Dr. Kamat, this has been a great conversation. I can't thank you enough for giving us your time and sharing all this really helpful information with our listeners.
Thank you guys for having me, and I really look forward to working with Peds Create Podcasting. I think we can team up together between our podcast, which is PICU Doc on Call.
Yes, absolutely.
And I think we should come together to provide good knowledge for those interested in pediatric critical care. Thank you really for having me today.
Oh, yeah. We look forward to many more crossover episodes and continue to contribute to the online community of Peds ICU learners.
Sure. Thank you guys again.
Thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. Check out pedscrit.com for detailed show notes, and visit @CritPeds on Twitter and @PedsCrit on Instagram for real-time show updates. Thanks again for listening.